now being recorded.
All right, we're going to get started here. Welcome to our monthly MyCRC Connections live chat. If this is your first time in the chat room, welcome. MyCRC Connections is the Colon Cancer Alliance official online community, and I'm Nancy Butterfield, CCA's patient support advocate. I'm here with one of our buddies, Jean Angelette, who's going to be helping me out tonight behind the scenes as Jeannie's in St. Louis at a conference. Thank you, Jean, for volunteering to help me tonight. We really appreciate it. A few reminders before we start. The chat is being recorded and will be posted tomorrow in the archive chat section under the chat tab above. Your phones are muted, and after the presentation, we will open it up for questions in the chat room. You type your question in the small box under the smiley face, and I will read the question out loud after the presentation, and our speaker will do his best to answer them. Tonight's chat is about genetics and colorectal cancer. It's my great pleasure to introduce Dr. Thomas Weber, who has generously offered his time to be with us tonight. Dr. Weber's bio would take us all night to read, but here are a few highlights. He is a professor of surgery at the State University of New York at Downstate and chief of surgery at the Department of Veterans Affairs, New York Harbor Healthcare System. He is the current chair of the National Colorectal Cancer Roundtable and president of the board of directors for the Colon Cancer Challenge Foundation. He has published extensively on hereditary colon cancer and a frequent invited speaker on that subject at national and international meetings. He was recently appointed to the chair of the NCI Colon Cancer Family Registry Workshop Group and directs the Colorectal Cancer Research Program in the Department of Surgery at SUNY Downstate, and as a site director for the SUNY Downstate Department of Surgery Residency Program at the Brooklyn VA. Whew! Thank you, Dr. Weber, for giving up your evening to spend some time with us, and welcome to our community. The floor is yours.
Thank you so much, Nancy, and thank you, everyone, for inviting me. It's a great pleasure to be with you and to talk to you about this very, very important topic. I just want to share with you that my connections to colorectal cancer run even a little deeper than Nancy mentioned. I lost my aunt to colorectal cancer, and my mom at 87 is a survivor. So this is a problem that I and my family are very familiar with. I just also want to say, as we get started on this very complex topic, that I know that most of you on the call most likely have been affected by colorectal cancer, and I know many of you probably were affected at a young age. So talking about these syndromes, I know is very, very important and very special to everyone on the call. I also know that while some of you may have had access to genetic counselors and may already know quite a bit about why you developed your colorectal cancer, many of you probably have not had that opportunity or are perhaps very anxious about even exploring that opportunity. So with those sensitivities in mind, I'm hoping that tonight's discussion is really of practical value and is supportive for all of you as we go forward. I also want to mention that I think this topic is really, really important on many, many levels. And the first thing I'd like to just focus on is the tremendous importance and value of being aware of family history. I think my profession has not done as well as it could to teach to our medical students and promote amongst ourselves the real importance of taking careful family histories, because you don't really need to know a great deal about genetics, and certainly you don't need to know about the details of mutations and what have you. to be able to identify individuals and families who are at increased risk for cancer, including and especially colorectal cancer, based on a thoughtful and diligent family history. So I think that's one important starting point. The other point I'd like to share with all of you as we get started is one of the reasons that I find this area so engaging and so important is that just framing the issues and talking about it brings us face to face with the big questions of why do any of us get colorectal cancer? And if you look at the totality of what we know about the genetics of colorectal cancer, it doesn't explain every case. That's true. But it does really get us started on the journey to understanding ultimately every case. And that's the way I like to look at it, and that's what really inspires me to pursue this work. So having said that, let's get started. And again, it's a vast topic, so I've selected a number of key points that I think are important, and I hope they're important to you. But I've made a pledge that I'm not going to go beyond 25 or 30 minutes, no matter what. And we'll open it up for your questions, and I look forward to that very, very much. I just want to again frame the importance of this issue of family history and colorectal cancer. There's no question families in which one or multiple members are affected with colorectal cancer or even adenomatous polyps are definitely at increased risk for the disease. And that, again, is why taking a family history, being aware of your own personal history, is so very, very important. But this risk really goes up dramatically when we start to talk about the known hereditary or familial colorectal cancer syndromes, which we're going to do momentarily. So I think that's a reminder of why all of this is so very, very important, and it's so important for us all to be aware of these syndromes and their characteristics. So let's jump in, and I'm going to talk about the major hereditary syndromes, and I'm going to do it on a couple levels. I'm going to try and provide a quick overview of their basic characteristics. We'll talk a little bit about what we know about the genetics, and then I'm going to try and include some thoughts about what we know about the best surveillance techniques and clinical approaches, and some of the surgical aspects of that. And then we'll also we'll talk a little bit about some of the genetic challenges associated with each of these syndromes. I just want to underscore again, one of the very compelling challenges about what we know about this is that up to 20, 25, and in some series even 30% of all the colorectal cancers diagnosed in the U.S. occur in families where if you do take a diligent family history, you can see that other people have been involved, and the family history suggests that there's a genetic component. That's a huge percentage. But having said that, our current knowledge of the genes that can increase a person's risk of colorectal cancer really only accounts for less than 10% of all the cases that we know. So that means there's a great deal more for us to learn about the genetics of colorectal cancer, and that again is why I think it's so important. So there are really three major hereditary syndromes that are discussed in conversations like this. And so we'll go over them. And those three are familial adenomatous polyposis, or FAP. The second one is the Lynch syndromes, or hereditary non-polyposis colorectal cancer. And then in recent years, there's been some very, very exciting work on what is called the MYH, or mute-Y syndromes. And they are also important, and they have some different characteristics from the others, which we'll touch on. So let's just talk a little bit about familial adenomatous polyposis. FAP is a very dramatic form of hereditary predisposition to colorectal cancer, and I say that because individuals who are members of FAP families and are affected, and I realize this could be some of you on the call, have very large numbers of polyps in their colons, measured in the many, many hundreds, if not thousands. And these polyps can begin at quite a young age, and certainly in most patients by adolescence, these polyps are present. And as many of you will probably know, our understanding of colorectal cancer is that it arises from polyps. So, not meaning to oversimplify, but you can imagine that if a person is carrying hundreds, if not thousands, of polyps, the risk of colorectal cancer developing one of those polyps dramatically goes up. And that's the case for familial adenomatous polyposis. It's a dramatic syndrome, but it's relatively infrequent. Not exactly rare, but infrequent, and it accounts for less than 1% of all colorectal cancer cases that occur in the United States. But it's important for many, many reasons, including the fact that when members of FAP families are identified, they can be screened on a regular basis, and if indeed they are carrying many, many polyps, then discussions can be had about surgical procedures that remove the colon and the rectum to dramatically reduce the number of polyps present and protect the patient from that increased risk of colorectal cancer. So that leads us to acknowledge why the revolution in genetics and genomics is potentially so very, very valuable. Before we understood the genetics of FAP, every child born into a FAP family was destined to most likely have to undergo some sort of surveillance and endoscopy to see what the situation was in terms of polyps. But the great advantage and one of the main inspirations for studying the genetics of these diseases is if you can identify a mutation in a high-risk family and you know what it is, then members of the family can be tested specifically for that alteration. And if you're a carrier, then yes, you're at increased risk. But if you're not a carrier, then your risk is then the same as the rest of the population. In other words, you're really not at increased risk. So this really allows providers and families to be much more selective about who needs to go through these somewhat invasive screening procedures. So FAP has now been shown to be associated with alterations in what is called the APC gene. And as some of you may already know, APC means altered in polyposis coli, which I know sounds very technical, but but fits the description of the syndrome. So again, individuals who are in families at increased risk can undergo genetic testing, ideally with the help of a genetic counselor, and be tested to see if they are carriers. One important thing about FAP is that, although again, I want to be reassuring, it's relatively rare, it does have a significant rate of what we call spontaneous mutation in the human family, as it were. So it is possible for new mutations in the APC gene to pop up in individuals and families where it wasn't recognized previously. And so it's important for people to be vigilant about that. And certainly, if you're in a high-risk family, even if there's no previous evidence of FAP or APC gene alterations, it's going to be something that's on the list that should be evaluated. I think another important thing to share about FAP, and is something that we certainly discuss with all of our patients, is most of these syndromes are associated with increased risks and issues at other areas of the body, which is very important. So for FAP, one of the big issues are also having polyps in the upper small bowel. So that means that individuals with FAP really should be under regular surveillance by their endoscopist or surgeon to be checking for these other areas of polyps so that they can be removed before they become a problem. So it's very important to have a diligent follow-up. And I, of course, realize, our great country is vast, and many of us live in areas where we don't necessarily have easy access to centers of excellence. But all the same, whenever possible, I think individuals who are dealing with any of these high-risk syndromes ideally really should be under the care of people who have a lot of experience with it and can be the most helpful and the most supportive based on that experience. Let's just say a few words about how surgery can be helpful in FAP in particular. As I mentioned, the goal of surgery is to remove the colon and the rectum to reduce the risk of developing a colorectal cancer. As you can imagine, a lot of risks and benefits have to be weighed, including what's the optimal and best time to do this procedure, particularly as many of the people affected are quite young. So ideally, discussions about surgery to protect individuals usually take place in late adolescence and are often timed to when young people have certainly finished high school, maybe getting ready for college or in their early years of college based on how they're doing clinically. But this gives people time to mature and be prepared. Again, I want to stress, FAP is a infrequent cause for the overall colorectal cancer burden in our country, but it's important to know about, and clinicians and scientists who are dedicated to understanding colorectal cancer have learned a great deal by studying FAP, and it has really helped our understanding enormously. I just want to stress again that, just to be clear, genetic testing for FAP is available. It's a fully approved procedure. It's covered by many or most major insurers, and I realize not everyone has access readily to that insurance, but it is a standard of care. So it is something that should be readily available. So let's move on to the next major syndrome because time is flying. The next major syndrome is the so-called Lynch syndromes, named after Henry Lynch, and not to be confusing, but as many of you will probably know, they're also called HNPCC, which is an acronym for Hereditary Non-Polyposis Colorectal Cancer, which of course is totally confusing, very, very confusing, because the confusing part is that members of Lynch families or HNPCC families do make polyps, but the numbers are dramatically less than in FAP. So you recall when we talked about FAP, we were talking about many, many hundreds, if not thousands of polyps. That's not the case for the Lynch syndromes. It's really not anywhere near that. It may, in fact, be something that's measured in the tens or 20s or even less. But the issue is that members of these families also carry a significant increased risk of developing colorectal cancer during their lives. I know we want to stay on time, but I think sometimes it can be very compelling to include some stories and anecdotes about how we came to understand these syndromes. And the Lynch syndromes are particularly interesting. At the turn of the century, there was a professor of pathology at the University of Chicago, Dr. Warthen, and he recounted how one afternoon one of the members of his staff, young woman, came to him and told him that she was very, very concerned that she was going to die of cancer because so many members of her family, especially women, had died of abdominal cancer. And, instead of moving on to something else, he took this young woman's concerns very, very seriously, and he worked with her over a long period of time to develop a very careful family history, or what we call pedigree, of the family. And unfortunately, several years later, the young woman passed away. But by that time, Dr. Warthen had really documented many generations and had shown the pattern of inheritance of these cancers, which were actually endometrial or uterine cancers and colorectal cancers. So to move the story along, a number of decades later, it was Henry Lynch at Creighton University in Nebraska who came across Dr. Warthen's report in the Journal of the American Medical Association and became inspired to understand what was going on. And living in 2011, some 10 years plus after the Human Genome Project and the world we live in, we take some of our current understandings for granted. But it wasn't many years ago that many clinicians, many doctors were not at all convinced about the issues of familial cancer, including hereditary colorectal cancer. But we owe a great debt to Henry Lynch and the many people who worked with him as he really pursued an understanding of this syndrome, and that's why it's referred to as Lynch syndrome. Let's just talk a little bit about this issue of other parts of the body being affected in these hereditary colorectal cancer syndromes, because I think it's important, and it's especially important in the Lynch syndrome or HNPCC for reasons that I kind of alluded to just a minute ago. The family that Dr. Warthen studied, as I mentioned, was also affected with endometrial cancer. So in the Lynch syndromes, our major concern is colorectal cancer, but there is also an increased risk of endometrial cancer, and so members of these families really should be screened on a regular basis. And there are controversies about the best ways to do that, and we can talk about that a little bit later on. But the most important thing is for everyone to be aware that that's an issue. And then there's also an increased risk of what doctors call upper GI malignancies, which is just a technical way of referring to the fact we need to be very careful and do surveillance and be aware for gastric or stomach malignancies. And also there's a slight but significant risk of malignancies of the urinary tract as well. So again, I appreciate and I'm very sensitive to the fact that many of you are probably trying to figure out where you are on this spectrum. I want to be reassuring that these other cancer risks are not nearly as high as colorectal cancer for these families, but they are there. And again, it underscores the value of being, or at least having access to centers of excellence that can be diligent and thorough in taking care of members of Lynch families. Let's talk a little bit about some of the genetics here. Both FAP and the Lynch syndromes are part of what geneticists call autosomal dominant syndrome. So, forgive me, I'm not trying to get technical. I think it's easy enough to follow, and I'm going to explain it. Autosomal dominant simply means that if you're a member of one of these families, your risk in that family is 50-50, which means that if either your mother or father is carrying the gene, your risk is 50-50 whether you're going to acquire the disease-causing gene, and it goes through the generations in that way. I think another thing that is helpful to share is because there are multiple types of hereditary colorectal cancer, doctors and clinical providers have needed some sort of fairly straightforward criteria to try and organize the information, especially before we knew what we now know about the genes. So one basic rule that doctors have used over the years is the so-called Amsterdam criteria, or 3-2-1 rule, 3-2-1, which refers to the fact that Lynch syndrome families are characterized by there being 3 affected individuals across at least 2 generations in the family, and that one of those affected individuals has to be 50 years of age or less at the time of diagnosis. And this is another general takeaway point, that so far in our efforts to understand genetic or hereditary predisposition to colorectal cancer, early age of onset, which I know is an issue for many of you, early age of onset can be a clue or an important point that needs to be followed up on if diagnosis is made at a young age. So early age of diagnosis should always prompt interest in assessing family history and possibly looking at the genetics. Doesn't mean that we're going to figure out exactly what the genetic issues are for every individual who's diagnosed at a young age. And that's very similar, not to go too far afield, but just to share, very similar to the situation for breast cancer, where remarkably a majority of early age onset women affected with breast cancer who are tested for the BRCA1 and 2 genes, the majority of them we don't find mutations, which is sometimes frustrating, but is also a reminder of how much more important work there is to do to understand the situation, and that's the case for colorectal cancer as well. I don't want to get too technical, but I think it's a good idea to just share some of the names of the genes that we're talking about when we talk about Lynch syndrome. So, as some of you may already know and have probably read, maybe in more detail than I have on the internet, the genes associated with the Lynch syndrome are the so-called DNA mismatch repair genes. And they're called that because their job in the cells of the body is to make sure that when our cells divide and we replicate the DNA, that it's done perfectly. And the DNA mismatch repair genes make proteins that literally scan the DNA that's being duplicated to make sure that there are no errors. So you can imagine that if unfortunately you carry a mutation in one of your DNA mismatch repair genes that affects its ability to perform that function, then there are going to be errors, and we refer to that as replication errors, which affect the fidelity of the DNA replication, and that leads to the best of our knowledge and current understanding, that's what sets the stage for an increased risk of developing a cancer. So the mismatch repair genes are really the focus for the Lynch syndrome or HNPCC. The predominant ones are MSH2 and MLH1. There are others as well, but most of the mutations that are identified are in MLH1 and MSH2. I'm just going to, again, not to get too technical here, but I just want to share one other point that some of you may have already confronted, and I want to acknowledge it right away because it's an important challenge, and it's also a major part of our own research and clinical research. When people are referred for genetic testing, which I think is a very important and very good thing by and large, one of the issues is if an alteration is found in one of the mismatch repair genes, there are different types of alterations. Some of the alterations cause a definite, dramatic, limiting effect on the proteins made by the gene, and there's no question that it affects its function, and it explains why the person is at increased risk. But there are some other alterations where it's less clear, where the protein is less dramatically affected, and that can be very challenging for patients, families, and genetic counselors. So I just want to mention, because I always try and look at these things as the glass is half full, there's a very, very robust international effort to understand these alterations and to characterize them and to make it clearer for clinicians and families which ones are really significant and which ones are much less of a risk. So those are called unclassified variants, and our group and many of the groups that we work with are very focused on that issue. Okay, I'm just going to mention briefly one other major syndrome, and then I think we'll try and go to questions because time is flying, and I can't see you, and I don't know how many of you I've already put to sleep. But the third major area that's important are the MYH or MUT-Y syndromes. And this is another class of genes where mutations have been identified to be associated with increased risk of polyps and colorectal cancer. But, and this is important for clinicians, patients, and families, we talked a little bit earlier about so-called autosomal dominant syndromes with a 50% risk and where we see multiple generations being affected. The MUT-Y or MYH syndromes are very, very different. They are part of what are called, and what many of you may have read about, so-called recessive disorders. And that means that having the alteration alone from one of your parents is not necessarily associated with an increased risk. You need to inherit it from both of your parents to have an effect. It's kind of like having blue eyes. Of course, having blue eyes is much better. But it's the same basic genetic idea. It has to come from both parents. And so that means when you look at a family that's dealing with this issue, you're not necessarily going to see colorectal cancer cases in every generation as you look back. You won't. There will be multiple generations where you won't necessarily see anything. But then all of a sudden, excuse me, you'll have a generation where multiple siblings, brothers or sisters are affected, and that's a clue. And that should prompt some thought about looking at the possible issue of the MYH or MUT-Y genes. And that's important because in not too many years ago, before we understood about MUT-Y or MYH, families where there wasn't really any family history before the generation in question, people were uncertain whether they were uncertain what to do. Now we know what to do and what to think about. So I think this might be a good time to open it up a little bit. We're 40 minutes after 8 o'clock, and I would be delighted to take any questions. Unfortunately I can't be your doctor, as it were. We have to be thoughtful about any specific individual clinical recommendations, but we certainly will do everything we can to answer your questions and try and point folks in the right direction with any issues or concerns that you have. So,
great. Okay.
And then be happy to open it up.
Great. Well, thank you, Dr. Weber, for that wonderful presentation. I think you described things pretty well, and I do appreciate that. We're going to open it up for questions in the chat room. So if you can type your question into the box under the smiley face, I will take them in order from the MyCRC Connections chat room. What I'm going to do is I'm going to read a question that was emailed to me while you all are typing your questions, and then I'll read those in order for the doctor. So here's a question that was emailed to me. It's from Mina. I was diagnosed with Lynch syndrome, stage 1, at the age of 47. I had microsatellite instability test positive 9 of 9 samples. On the later DNA sequencing test, I got MS6H mutation. I only had surgery, right hemicolectomy, for my treatment, as recommended by doctors. After I had my surgery, I had my son get his first colonoscopy at the age of 22 and found that he had a cancerous polyp. It was removed by the GI doctor who performed the procedure. In July 2010, during the colonoscopy procedure, he had another cancerous polyp removed, and he just turned 25, and they are of Asian descent. Here's a question. It's 5 years since diagnosis. It seems she lost her connection with her doctors. What should she do to pursue a follow-up surveillance plan? What plan should she do at this time?
Okay. Well, I think that's a really important set of questions, and there's a couple of big issues that stick out at me. Number one is the questioner mentioned, if I understood correctly, that she had an MSH6 mutation.
Yes.
Now that's important. I'm going to assume that mutation was interpreted to be a significant one. I'm just going to make that assumption because that's the information the patient was given. So that's important, and so a couple of things stand out. I think one thing which may have already been done, but is probably important, is to see if the patient's son or any of her other children are carriers of that mutation. So that's one thing, and I appreciate that the patient is probably already well aware of that, and I'm working my way towards the most difficult question she asked. Second thing is, regardless of mutation status, sounds like her son is definitely at increased risk. So her son really, as I'm sure she already appreciates, needs to be under very careful surveillance, and then that's her key question. So I'm going to throw a couple of things out that might be helpful to everyone. There is an outstanding nonprofit group called the Collaborative Group of the Americas for Inherited Colorectal Cancer, or also known as CGA, and I believe their website, please don't quote me, but I'm pretty sure it's, and I could check after I finish concentrating on providing a good answer here. I believe it's www.cga-icrc.org. And I mention them because this outstanding group, which again I stress is a strictly not-for-profit group led by Dr. Jim Church at the Cleveland Clinic. This group brings together surgeons, medical oncologists, and researchers who are focused on hereditary GI cancer issues. But the other really important thing about this group is they also bring together all the cancer family registries from North and South America, and the genetic counselors and outstanding nurse practitioners and other folks who run all of the high-risk colorectal cancer registries in the country. And I believe, I'm quite confident that on their website they list the registries. Now, I don't know exactly how up to date it is, but I'm very confident that it's probably one of the best working lists that we have access to in the U.S. And I would encourage the questioner to take a look at that, and that might help guide where to go next. But certainly, wherever she is in America, I would look to the closest university medical center, and I would reach out to the GI department there, or the Department of Surgical Oncology or Medical Oncology, or if there's a genetic counseling service, I would touch base with them and try and organize your next steps through them. Okay. I hope that's helpful.
Yeah, that's. I think you've answered that. Is there a benefit or harm of having an annual PET scan to keep this in check?
Did you say PET scan?
Yes, PET.
Wow. Well, that's a good one. Well, PET scanning has a lot of value, but I'm not an FDA expert, but let me say this: PET scan has enormous value in following patients who unfortunately have been diagnosed with cancer. Was your question in reference to the?
It was in reference to the same question here with the Lynch.
Yeah. Well, I have to be honest. I am not aware of PET scanning as a modality for surveillance for any of the GI syndromes. I'm not saying that it wouldn't necessarily pick something up, but I think with all these tests, there are issues of sensitivity and specificity. So I think it probably has a role in people who have been diagnosed with invasive cancer. Most medical oncologists use it to follow and assess people who have had colorectal cancer diagnoses, but I don't know that you would use it to screen in members of high-risk families.
Yeah. Okay. All right. So I'm going to move on to the chat room here to some questions. The first question is from Julie. Multiple direct family members with cancer, but none colon. She's a 39-year-old mother. But me at 39. Okay, she got colon cancer at 39. Her mother got ovarian, her maternal grandmother, and her maternal aunt was brain cancer, maternal aunt breast. Any known correlations? Should she be genetically tested?
Okay. Well, Julie, I would say that number one, again, going back to some of the first principles we talked about, you were very young when you were diagnosed. 39 is, you may not feel every day that it's young, but it's young in the spectrum of ages of diagnosis. So I think the simple answer is yes. I think it would help you a great deal to talk to a genetic counselor about your family history, and I think your early age of onset is very important. And you said a couple of other important things. You mentioned in your family an ovarian cancer and a breast cancer. Now, two things, not to get too technical here, but two things that come to mind. There is certainly an increased risk of ovarian cancer in the Lynch syndromes. So that's one thing. But the other thing, as many of the listeners will know, there are also high-risk syndromes associated with breast and ovarian cancer. There are also, bear with me here, but I'm respecting every aspect of your question. There are some reports suggesting increased risk of brain cancers as part of both the FAP and the Lynch syndrome. So I don't say all these things to increase your anxiety level, but rather to agree with you. I think your instinct to seek out and secure genetic counseling, go over your family history, and explore it is a good idea.
Okay, thank you very much. And I'm going to massacre this word because I can't say it very well. But Karen asked, how long does it take adenocarcinoma of the colon without KRAS mutations to grow? Okay.
All right. Well, this is a very sophisticated question, and as the questioner knows, and probably many of the other listeners, KRAS alterations. This refers to genetic alterations, but importantly, genetic alterations that have taken place in the tumor itself. So, we make a big distinction here, and I'm just going to stress this for 10 seconds to just try and maximize the educational opportunity and help folks along, because it can be very confusing. I remember when I was getting started, it certainly confused me. So when we talk about the genetics of colorectal cancer, we've got two big arenas. We have alterations that can be passed on from generation to generation, and those are called genomic alterations. So those are the ones that are passed on. But then we also have issues to do with so-called somatic alterations, and those are the many, many changes we see in the genes in the tumors themselves, DNA taken from the tumors themselves. And the questioner is really referring to some excellent recent work that shows different response treatments to therapy based on KRAS. So I would say this. I don't know that we necessarily know that the KRAS alterations affect the progression from adenoma to carcinoma. And one of the things that may have prompted the question is the questioner may have done a lot of reading and know that one of the really big issues for both FAP and HNPCC is that the time of progression from polyp to invasive cancer is much, much shorter than in the general population, which is why increased frequency of screening colonoscopies are really needed to protect people. So, bottom line, I'm not aware of literature that the KRAS alterations necessarily affect that time period. It certainly is possible because we know it affects response to therapy. But I would say, I'm sure, obviously your medical oncologist has tested it and is going to adjust therapy based on that. But I have to be honest, I'm not sure that we know if it affects that specific timeline. But
okay.
That's a great question.
Okay. And then Karen asked, do you think the comprehensive Cloris covers all that we discussed?
Okay, so the Cloris, to the best of my knowledge, refers to the Myriad product line, and I don't have it right in front of me. I could certainly bring it up online, but Cloris to the best of my knowledge, really is designed to certainly cover the primary mismatch repair genes. I'm going to look as we're talking, and I'm sure the questioner is already looking, but it's important to stress that the vast majority of alterations are MLH1 and MSH2. I would say this: if Karen and her family have abundant evidence that multiple people in the family have been affected, then certainly under the supervision of a genetic counselor, Cloris is a reasonable place to start. But if Cloris doesn't give you an answer, then I would not stop there. So I'm just going to look while we go on to the next question.
Okay. Dee asks, are there other suspected genes involved with Lynch? I have a clinical diagnosis of Lynch, but tested negative for known genes 4 years ago.
Okay. Well, this is one of the things we were just touching on. I would say this. I think this is a fair and could be a valuable thing to say. I spend a fair amount of time with the laboratory geneticists who work clinically on these issues, and I would say that the field is advancing steadily, and our understanding of what can be a significant alteration is dramatically increasing. I was just at the International Society of Hereditary GI Malignancies meeting a few weeks ago in San Antonio, and we had a major session on this. And I want to reassure the questioner that there really have been significant advances. So my respectful recommendation would be to revisit it. Of course, the other question for the questioner is whether or not the cancer was microsatellite unstable, or whether the immune histochemistry was positive. That's often the first staging step. So, certainly if it was MSI unstable or there was immune histochemistry evidence, that would be very, very important. But I would say, and I think this is important, if it was a number of years ago that you went through sequencing, I can assure you our knowledge of what other issues can affect the function of the mismatch repair genes has increased dramatically. So I would support your instinct to revisit it.
Okay, that's very good. And then we have a question from Robin. I'm a Lynchy with MSH2 mutation and fit the 321 profile. At what age should my daughter start being screened with blood tests? I was 42 when diagnosed, but think that 32 may be too late to start that process.
Well, I think Robin is right. I think the basic rule of 10 years before is a good safety margin in general for the population. But if you're a carrier, I would certainly say early 20s. I'm sorry I didn't catch what age Robin's daughter was, but I agree with you. I would certainly check in her 20s, and since you have a mutation, it suggests that you have some access to a center of excellence, and I would think that the gastroenterologist there would really want to be on top of that. But I agree with you. The recommendations are certainly in your 20s. So I think you're right.
Okay. And Scott asks, regarding exercise and healthy eating as preventive measures for CRC, is it more beneficial, less beneficial, or the same for those with genetic mutations such as Lynch or those without?
Well, that's a great one. And I think, we all, as many of the callers will know, we have agonized a lot with some of the level 1 evidence on diet and colorectal cancer risk. But I think there's broad consensus that healthy diets and exercise are are useful, but I understand exactly where the questioner is coming from. And I think what the questioner is reminding us of is that if you are a carrier of a known alteration and you're at significantly increased risk, the most important thing is to be under a surveillance and clinical supervision schedule that's going to protect you. That's job number one. Because eating healthily is not necessarily going to do the whole job for you. Having said that, I don't think we should be fatalistic about the value of healthy diets and exercise. My feeling is it remains very worthwhile and in everybody's interest. But I think the caller makes a good point. It's not going to be fully protective, and there's no substitute for diligent clinical surveillance and careful follow-up with your doctors.
Okay. And then Ethel has a son whose Lynch is, she has Lynch with the MSH, and that's the same as Mina. So you two need to talk there. And her son tested, first colon test, and it was fine. So that's good news, Ethel. And then John asks about the KRAS mutations, about treatment for recurrence implications.
Yeah. Well, recurrent disease, again, the KRAS alterations can help the medical oncologist in some of the decisions, but I think if unfortunately you're facing recurrent disease, you want to keep your options wide open. Your medical oncologist, I'm sure, is going to make some initial decisions based on the KRAS, but you want to see how you're responding to those initial options. Obviously recurrent disease is a very, very serious issue, but on the positive side, the newer agents, particularly over the last 10 years, have made a real contribution. So I think I would keep my options open and work with your because that's your right, and I think that's the way I would approach it.
Okay. And then somebody was asking about the website for Dr. Jim Church, the collaborated group.
Yes. Let me see if I can find it.
Maybe we can address that at the end. So let me finish through these questions here. If you want to look for it, I'll address the next question.
Sure.
It's and I do. Let me know if I'm wrong here.
Yeah.
Where can one find centers of excellence? I think what that would be the National Cancer Institute would be facilities that are on the list there. So. Dr. Weber, is that what you would say, the National Cancer Institute, the list of facilities that are on that list?
Yeah, let's say a few things about that to try and be maximally helpful. The NCI does keep a list of what they call comprehensive NCI cancer centers, and certainly if you have access to a comprehensive NCI cancer center, I would go there. Having said that, unfortunately, our great nation can't afford or hasn't prioritized resources to have an NCI comprehensive cancer center, every few blocks. So most major cities have one. Just about every university medical center aspires to have one. But again, to be reassuring, there are many excellent university centers that are not necessarily NCI comprehensive cancer centers who have excellent services and excellent providers. But yes, if you have access to an NCI comprehensive center, I would certainly consult with them and work with them.
And I just put that link up there, so you'll see it in the last box. I just put the link for the NCI cancer centers.
Okay.
But as Dr. Weber said, they're not everywhere, and there may be a center that can help you near you, but that's a place you can start and see if they can help you, and if not, they could probably refer you to somebody that can. So,
yep.
Okay, and then Laura asks, I went in when I was about 30 to see if I had polyps, and they found 5. Every 3 months after they That, they found 5. I reached 20 polyps prior to getting pregnant with my son. After giving birth, they found a few hundred polyps. I had my colon removed. My small intestine and rectum was resection. For 4 years, I didn't have any. Now they are coming back in the rectum. 3 in my stomach and 1 in my upper small intestine. A mass on my lymph node and mass on my duodenum.
Duodenum.
Duodenum. I can't say that word either. At what age is it recommended that genetic testing or cancer surveillance start in those who have a parent? Wait a second. I don't know where the end of her question went. I'm sorry, Laura.
Well, that's okay. I can sense the high points here, and Laura, I'm sorry that you've been through all of this, but a couple of things.
Oh, here we go. I'm sorry. She wanted to know, genetic mutation occurring while she was pregnant greatly increased her son's risk while she was pregnant with him, especially if I developed a few hundred while I was pregnant. So she's wondering about her son.
Okay. All right. Well, I think we can tackle that. Let's say this. I'm very confident that your polyps developing when you were pregnant, it wasn't necessarily the pregnancy, and whether or not you pass anything on to your son is really based on whatever the genetics of your increased risk are. So I know that sounds a little convoluted, but I'm trying to reassure you to don't blame the victim here. It really depends on what syndrome we're dealing with. So I think step 1 is for yourself to have access to a genetic counselor and go over this history and be tested, and then based on that information, when you feel it's right and your family feels it's right, and if your son is okay with it, then he could certainly be tested to see if there's any increased risk. But the questioner certainly needs to be under the care of a group that is very savvy about this. I'm particularly interested to hear about the duodenal polyps. That really needs to be followed very, very closely.
Okay, thank you. And then Martha asked, I was diagnosed with colon cancer at 40, tested positive for Lynch, had a colectomy and hysterectomy. Both my parents passed away of colon cancer at ages 57 and 62. My sister has endometrial cancer at 45. My daughter is now 19. When should she be tested?
Tomorrow.
Yeah. Okay.
That's just, that, I don't mean to sound melodramatic, but, again, I'm a glass is half full kind of guy. So you have a 50-50 chance that the news you get from that will be immensely reassuring to both you and your daughter. If we're unlucky and she's a carrier, you and she need to know so that she can be under proper surveillance. Because risk reduction surgery for people who are carriers makes a huge difference. So, I want to stress, I know these situations can be overwhelming, if not just totally exhausting. But
if somebody gets colon cancer at the age of 19, would that be a genetic mutation? Would that always be some sort of, or is it possible that a 19-year-old can just get colon cancer? I mean, just for no other reason.
Well, Nancy, as we touched on, and you're asking a great question, but 19 would be very, very young, and so any diagnosis at that age should really prompt a thorough family history review and really diligent work with a genetic counselor and genetic testing, without question. Whether you'll absolutely find the definitive mutation, that's going to depend. So, but going back to the questioner, the take-home point is it can make a life-saving difference to have risk reduction surgery, particularly regarding the colon, if you're a carrier. So I would say tomorrow.
Okay.
You'll feel a lot better. You'll feel like you're taking control which you will be, and you'll be taking positive steps. And I know it's a little scary, but either way, you'll be making a real contribution to helping your daughter.
And she also follows up by saying she hasn't been tested for a syndrome. She's worried about repercussions from insurance company if she tests positive. Is there still a risk of insurance companies dropping people from insurance?
Well, this, of course, is a major and valid concern that reverberates across the country. The Congress has passed a non-discrimination act based on genetic predisposition. The literature is very reassuring that there have not been cases, particularly with regard to health insurance. I know people are sometimes then anxious about life insurance, but I think these things cut a number of different ways. If you have a documented history of early age onset cancer, any and all insurers will know about that. If I'm not mistaken, the Healthcare Reform Act addresses a number of these issues, and as it's implemented, would definitely protect you.
Yes.
So I understand your concerns, but my instinct would be for your own peace of mind and to really sort out what the risks and the protective actions. There are, as I said, there are steps that could be taken to protect your daughter and other children if they're carriers. I would certainly encourage you to take the initial steps and discuss it with a genetic counselor or a medical geneticist. Discussing it doesn't commit you to do anything, but it helps you get started on a road to finding your own comfort level with you and your family on what you feel is best to do.
Okay. And then Karen comments, she was the one that...
Yep, I remember Karen.
Okay. So she says it lists, and I'm sorry, I was scrolled further up, so I did not see this. She answered your question when you asked her. She says it lists MLH1, MLH2, and MSH6, PMS2, and ECHAC, ECH, ACH.
Mm-hmm. Those are the ones that were tested?
Yes.
That's a very thorough list. So if the question is if they were all negative and she's still concerned, again, I'm really serious about the steady advances in understanding these issues. So I would keep working on it with your genetic counselor. Again, I don't want to sound naive about cost and expense, but these advances are real, and if expense issues are an issue, I'm sure your genetic counselor or medical geneticist or oncologist can help make the case that it's important to stay vigilant and to keep searching for what the issue is. I'm assuming that it's not a FAP APC gene issue and it's not an MYH issue. It's important to keep those things in mind and make sure they're not at play. That can be very important.
Okay, so she said she just had her test drawn today and she will keep a check on it.
Okay.
Okay, great. Then the next question is from Laura. Are there vitamins that could help fight polyps from developing?
Okay. Well, this is an important one. So, and I'm just checking my notes to give you the best information here. But interestingly, there are some strategies for, particularly for FAP. For FAP-related polyps, there have been some studies that have focused on the so-called COX inhibitor drugs. The problem is that some of those drugs have also, unfortunately, in the last few years, been associated with increased risks to do with increased risk of cardiac disease. But I want to make a recommendation here that I think it is somewhat technical, but it's out there for the public, and that is the NCI's PDQ website. I just want to make a respectful recommendation because you can go to PDQ. Let me see if I can find it very I think I had it on here earlier. Yeah. So the NCI PDQ website is an absolutely remarkable national resource, something you can be very proud of that your tax dollars have done. If you go to PDQ, you can literally put PDQ in your search engine, and it lists all major adult and childhood malignancies, including colorectal cancer, and there is a section there on the genetics of colorectal cancer. There's a health professions version. Now, I understand there's a lot of technicalities there, but this is an age where people are reading, and if you're going to be reading online, I would respectfully recommend reading the best evidence-based material that there is out there. So there is a section in there about chemoprevention for polyps, particularly in FAP. And there's still a lot of interest in the COX-2 inhibitors, but there are some safety concerns. But another agent that has been looked at and used is Sulindac. So I think I would ask your clinician about that. There's also some interest. There's a lot of interest in Europe about the possible role of aspirin in reducing the number of polyps, and there may actually be in the next few years there may actually be a major trial in this country looking at that for Lynch syndrome families. So the simple answer is yes. There are some interesting studies out there. There are some agents that have been reported to be helpful. Unfortunately, I have to tell you, none of these agents is an absolute protection, and certainly none of them really protect you sufficiently that if you're in a FAP family or a Lynch family, you can avoid the surgery. But still, sometimes these agents can be helpful to reduce total polyp burden, particularly in people who maybe it's not safe for them to have a major operation, or they've already had an operation and you're trying to control, say, polyps in the rectum. So yeah, there are some opportunities there. There's no silver bullet, but there are some opportunities.
Okay, and I have put that website. I just put it up on in our chat room, so you can access it through via what I just put up.
It's a major resource.
Yeah, thank you for that. Mina asks, could you please talk about the proctocolectomy for Lynch patient? What is your opinion on that?
Okay. Well, yeah, it's a big topic. Here's sort of the distillation of a lot of years of trying to understand what's best. Generally speaking, in the Lynch syndrome, risk reduction surgery has focused on total abdominal colectomy, preserving the rectum, because the general consensus has been that the risk of developing rectal cancer in the remaining rectum is not quite as dramatic as it is in FAP. So that's sort of been the historic distinction. The other issue, of course, as the caller may be very familiar with, is total proctocolectomy means either having an ileostomy or reconstructive surgery, and that's a big deal. So surgical oncologists and colorectal surgeons involved in this issue have tended to be cautious about total proctocolectomy. Having said that, if you're in a Lynch family, and certainly if you have a positive mutation, then the concern about rectal cancer along the entire course of your life into your 60s, 70s, and 80s is real. But generally speaking, what people have done is avoid the more challenging in terms of lifestyle surgery and accept the real risk reduction by having a total abdominal colectomy. But then everyone has to understand that the remaining rectum has to be under regular surveillance. And the challenge with Lynch syndrome, and the caller is probably well aware, is you have to be really vigilant about that. Because the problem with Lynch is that these polyps can transform very, very rapidly. So, most institutions will not accept a surveillance period of any less than every 2 years. And that's going to also be informed by what's actually happening. If the patient is still making polyps, every year, then you've got to stay on it. Now, if this particular patient, if our questioner is unfortunately someone with Lynch syndrome who unfortunately does have a very significant polyp burden in the rectum, and the gastroenterologists feel that they really can't stay on top of it, and that may be what's at issue here, then that's a slightly different ballgame. Because if you already know that the most motivated doctor and patient are not going to be able to stay on top of it, you can't spend your life having a colonoscopy every 2 months, then maybe the total proctocolectomy needs to be under consideration. But generally speaking, there's a distinction between how it's done between FAP and Lynch. And usually in Lynch, we try to spare patients the more challenging lifestyle procedure.
Okay, great. Thank you. So it looks like those are all the questions online that I've read them all. I just wanted to go back to the group, the Jim Church collaborated group.
Yeah, let me see. Forgive me, I'm trying to...
That's okay. While he's looking for that, I'm going to give you the website for the National Cancer Institute, which we talked about twice tonight, is cancer.gov. So that's a simple way of getting to that website. That's a National Cancer Institute that has the federally regulated facilities, cancer centers there, and then also the PDQ that he spoke about with the cancer topics, PDQ. That's at cancer.gov.
Okay, I think I've got the CGA for you here. Give me 1 second. Okay, here it is. So it's www.cgaiCC.com. That's the wrinkle. They have a commercial server at the moment. But again, I want to stress, they are a not-for-profit group. So I'm just looking to see here if they have on the left-hand side there is Find a Registry, and there are many registries listed here. So I think that's a start.
Great.
And
okay.
Certainly, and if you needed to, I'm sure callers could contact the Cleveland Clinic and check in if they needed to.
Great. Okay. Well, thank you, Dr. Weber, for that wonderful presentation. That was great. That really tells us a lot about both the syndromes there. I'm going to go ahead and let you go, and we just want to thank you, and I'm going to stay on to just give a notice about what's coming up next month, and I don't want to bore you with all our details, so I was going to go ahead and let you hang up, and we do appreciate you coming. Thank you so much, Dr. Weber.
Okay, Nancy, thank you. It really was a pleasure. I hope it was helpful, and I'm happy to be a resource for our Alliance colleagues and patients anytime that I can be.
Thank you so much. If the rest of you can just hang on for a second, I just wanted to tell you about next month's chat topic will be a webinar on clinical trials that you won't want to miss. It's Wednesday, June 1st at 8 p.m. Eastern Time. The webinar is going to explain what you need to know about a clinical trial, including how to be matched up with one. And something that was interesting to me, I always thought clinical trials were when you were at the end of any kind of treatment, but I understand that they are really for before you start treatment, and also when you're switching, when you're going to change any type of treatment, you should check into a clinical trial. So you might want to come and listen to our next month's chat. Watch the chat schedule for more details. And also, I just want to ask anyone that wants to leave a comment about what you thought about tonight's chat. It would be great if you could just comment in the chat room and let us know what you thought of it, if there could be any improvement or how you liked it, or just any comment that you have for us. That would be great if you could leave a comment in the chat room. And thank you, everybody, for coming. Have a great night, and we hope to see you next month, Wednesday, June 1st at 8 o'clock. Thank you so much. Take care. Bye-bye. Next month, Wednesday, June 1st at 8 o'clock. Thank you so much. Take care. Bye-bye. Next month, Wednesday, June 1st at 8 o'clock. Thank you so much. Take care. Bye-bye. Next month, Wednesday, June 1st at 8 o'clock. Thank you so much. Take care. Bye-bye. Next month, Wednesday, June 1st at 8 o'clock. Thank you so much. Take care.